Okay, I'll go ahead and get started. My name is Dr. Stacy O'Brien, and I'm faculty here in the Department of Family and Community Medicine. Welcome to our grand rounds for today. The directions for registering, if you are needing CME credit, are on the screen there. We'll have that information again at the end of the grand rounds presentation today. Next slide, please. We do have a new CME system, so if you have not registered before, the steps are on the screen there. The number to send the text with the email connected to your CME profile is there, and then step 2, the activity code for today. So you'll be registered for credit, and so the screen here shows the text message that you should receive, letting you know that you've been successfully documented for attending today. Next slide. As always, we are all very used to Zoom by now. So if you are not muted, please mute yourself. Once we begin the presentation for today, please be attentive to our presenter. We love questions, so if questions come up as the talk is going on, please type them in the chat box. I'll be keeping track of the questions, and we will address those at the end of the presentation. And then at the very end, there'll be an evaluation form for you to complete. You'll also get an email reminding you to complete the form. Please do that so we can give feedback to our presenters on ways we can improve our grand rounds presentations. Next slide. So again, this is the South Texas Regional Family Medicine Grand Rounds. We partner with the South Central Area Health Education Center here in San Antonio with the mission to essentially promote community health in South Texas and beyond through patient-centered care, research, and education. Next slide. Just another reminder for the CME transcripts, the website is there. cme.utesca.edu if you want to get a review of the CME events that you've attended over time. You should be able to view and print your transcript there. The contact information for the CME office for UT is on the slide as well if you have any issues or concerns regarding your CME credit. Next slide. This event today, our grand rounds, is also approved by the AAFP. And so if you have any questions regarding your CME credits as it relates to AAFP, the contact information is on the slide there, the phone number, as well as the email address. Next slide. Our grand rounds also address the nationally established physician core competencies affiliated with the Institute of Medicine's core competencies, the ABMS core competencies, as well as ACGME competencies, and then of course our AAMC competencies there on the screen. Next slide. There are no conflicts of interest for our presenter, Ellen Joseph, today, nor myself for the presentation for today. Next slide. And our wonderful psychology resident who we've had in family medicine over the past year, Ellen Joseph, will be presenting for you all today. So please give her your undivided attention. And as I mentioned before, if you have questions that come up as the presentation goes on, just please type them in the chat box and we'll address them at the end.
All right, thank you, Dr. Obaid. I'm really excited to be here today, y'all, to speak to you about IEPs and 504 plans in K-12 and beyond, and specifically talk about the role of primary care providers. So I wanted to provide a little background as to why I chose this topic for today. Psychology is actually a second career for me. I was previously a special education teacher and a special education coordinator at a charter school in Washington, D.C. And I learned a lot from that experience as to why education is so important in the outcomes for children and their families. I actually served a predominantly underserved population in the school where I worked, and I really got to see the impact of social determinants of health on high quality education as well as the additional services that are needed when disabilities or health conditions are present. So I'm really looking forward to talking with you all about this more and how we can partner with schools and families and service providers to really help our children and our families. Here's an overview of today's presentation. I'll start with some vignettes to help ground our conversation for today, provide a brief review of the literature, as well as just very briefly touch on some legislation and terminology. I'll explain what Section 504 and IEP plans are, specifically then review the role of the PCP, come back to those vignettes that we'll start with, and then talk about resources and have some time for questions. These are our learning objectives for today's talk. So first, I hope by the end of today, you're able to identify presenting concerns that are treated in pediatric primary care that may qualify for Section 504 or IEP plans. I hope that you'll be able to explain key differences between Section 504 plans and IEPs, as well as discuss 2 to 3 ways that you can support families who are seeking Section 504 or IEP plans. Okay, so some of you may have seen the title for today's talk and wondered why I'm giving this talk to a primary care team. What does your work have to do with educational access and quality for children and adolescents? This is a fair question, and I want to ground this conversation in a concept that is embedded in the work that we do, the social determinants of health. Obviously, when we think about our primary care services, your eyes are likely immediately drawn to the healthcare and quality icon here. We do so much at our clinics to improve the quality and access to healthcare for our patients. However, I want you to think more broadly as an interdisciplinary team. We work with social work to help increase access to housing resources. We have promotoras who are providing HEB gift cards to support folks economically. And we encourage patients to connect with others, their communities, and social organizations to improve their outcomes. I'm sure our list of examples could go much beyond what I mentioned here, but my point being that in many ways, we try to address multiple social determinants of health right here in our clinics. We do not, however, have as many supports or systems for patients' educational needs, which is exactly why I'm giving this talk. Medical providers are still the most trusted entity in our country, and patients come to us and tell us their greatest challenges, including their educational concerns. Therefore, I hope today's presentation provides you with some new ways that you can support patients by addressing their educational needs. So as I move into the vignettes, if you have a piece of paper or somewhere on your computer that you can jot down some notes, I'll explain at the end what I'd like for you to write down, but just have something that you can refer to now as well as at the end of the presentation. So for our first vignette, Dominic is an 8-year-old Latino male presenting to his first well child clinic at your visit at your clinic. You learn from Dominic's mother that he has a previous medical history of Crohn's disease. Dominic and his family recently moved to San Antonio, and Dominic is reportedly having a difficult transition to his new school. His mother shares that he has had 3 accidents where he does not make it to the restroom in time to have a bowel movement. His teachers report that there have been some instances where he was not able to immediately use the restroom because they were in the middle of a lesson or transitioning to classes such as gym or art. Dominic is embarrassed and has already missed 10 days in the first 2 months of school due to his GI symptoms. So if you could take maybe 15-20 seconds to write down 1 to 2 ways that you would support Dominic and his family during this well child visit based on their concerns. So go ahead and make note of that now. Okay. Now for our second vignette, Josie is a 10-year-old Chinese American female presenting to her well child visit. You have followed Josie for several years across her well child visits, and parents continue to report progressively worsening school performance, C's, D's, and F's. Teachers have reportedly described Josie as a slow learner in reading, and parents have been told to hire a tutor. However, Josie's family is unable to afford these tutoring services and are concerned about her declining performance. Her parents report that she has never been evaluated for a learning disability, but both of her parents notice a difference in Josie's reading abilities compared to her older sister, Maya, who was 12 years old. So again, let's take 15 to 20 seconds to write down 1 to 2 ways that you would support Josie and her family during this well-child visit. Okay, and go ahead and keep these notes handy because we will come back to these later. So this figure here helps to highlight the bidirectional relationship between education and health. So more specifically, higher educational attainment is related to positive health outcomes and vice versa. Additionally, this figure can be viewed from the perspective of educational deficits and chronic health conditions. And of course, like a true BHC, I also want to point out the contextual factors that can influence this bidirectional relationship. So while many of you may look at this and think, well, sure, that makes sense, I wonder how many of you explore ways to support children and families educationally during primary care visits. So more specifically, what can you do as a PCP to help patients receive the appropriate accommodations and/or specialized instruction needed to access their grade level curriculum? Today's presentation will focus on how our roles extend beyond the medical and behavioral management of conditions to include empowerment, advocacy, and collaboration with families and schools. So I want to start by providing some background information on the impact of chronic health conditions and learning disabilities on educational attainment, as these will be our areas of focus for today. We will later move into how our systems support these children and their families. So youth with chronic health conditions are significantly less likely to complete high school or a GED by 21 years of age as compared to same age peers without a chronic health condition. One study found that youth with cancer, asthma, diabetes, or epilepsy were at greater risk. And factors that attenuated this relationship included depressive symptoms, school absences, and grade repetition. Prior research also indicates that 20% of children ages 6 to 17 have a special healthcare need, which in this study was defined as a long-term physical, emotional, behavioral, and developmental disorder that require prescription medications and medical or educational services or affect a child's functional status. In this study, it was found that those with a special healthcare need were at increased risk for less student engagement, more exposure to bullying, more disruptive behaviors that threaten social competence and lower academic achievement. Findings further prove that functional limitations attributed to chronic disease and behavioral health problems comprise the key special healthcare needs subgroups that are at risk for poor school outcomes. So let's shift a little bit to talk about learning disabilities and educational attainment and beyond. So students with disabilities have high school graduation rate of 67.1% compared to the national average of 84.6%. And those with learning disabilities attend four-year colleges at half the rate of their peers. Only 17% of college students with a learning disability actually take advantage of disability services or learning resources at their institution. And then as we think beyond the educational experience and we move to employment, the unemployment rate for persons with disabilities is more than twice of that of those without disabilities. In 2020, 17.9% of people with a disability were employed, compared to 61.8% of people without a disability. So clearly, based on this information, the impact of chronic and acute health conditions and learning disabilities on children's lives is significant. So as we know, legislation and policy drive so much of the work that we do and impact our patients directly. I like to provide a broad overview of important legislation that impacts our pediatric population and their families, particularly those with various health conditions and learning differences. So the Individuals with Disabilities Education Act, or IDEA, which was passed in 1990, is a law that makes available a free, appropriate public education to eligible children with disabilities throughout the nation and ensures special education and related services to those children. The IDEA governs how states and public agencies provide early intervention, special education, and related services to more than 7.5 million eligible infants, toddlers, children, and youth with disabilities. Infants and toddlers, so ages birth through age 2, who have disabilities and their families, receive early intervention services under IDEA Part C, and children and youth ages 3 through 21 receive special education and related services through IDEA Part B. This legislation ensures that children with disabilities are prepared for employment and independent living following the completion of their primary and secondary education. A key aspect that I want to highlight about this legislation is that IDEA provides funding to educational institutions to provide these services. So they have the funds available to actually meet these children's needs. Section 504 is a federal law designed to protect the rights of individuals with disabilities in programs and activities that receive federal financial assistance from the U.S. Department of Education. The Section 504 regulations require a school district to provide a free, appropriate public education to each qualified student with a disability who is in the school district's jurisdiction, regardless of the nature or severity of the disability. So they have to educate these children and they have to meet their needs. To be protected under Section 504, a student must be determined to, 1, have a physical or mental impairment that substantially limits one or more major life activities, have record of such impairment, and be regarded as having such impairment. I will note that having an impairment does not automatically qualify a student for these protections. There has to be substantial limitation in one or more life activities. And this is really broad. So some examples of major life activities include caring for oneself, performing manual tasks, walking, seeing, hearing, speaking, listening, thinking, learning. It could be a lot of different things, just to name a few. So it's important to understand how the state within which you work implements and practices based on this legislation. I was always struck by how different these plans looked for students coming out of state when they were transferring to the school that I worked for, and how each state approaches special education services. So for instance, in doing my research for today's presentation, I learned that Texas will often place students with dyslexia, which is a reading disability, on a Section 504 plan rather than on an IEP. Whereas at the school where I worked in Washington, D.C., we never use Section 504 plans for dyslexia, given that these plans typically have less services and supports as compared to IEPs. So let's talk a little bit, pardon me, about what Section 504 plans and IEPs are. So the goal of Section 504 plans is for students to be educated in regular classrooms, along with the services, accommodations, or educational aids they might need. Modifications to curriculum or expectations of student achievement do not apply to these plans. They are also typically monitored by general education teachers as opposed to special education teachers. Here I've included a short list of accommodations that could be included on a 504 plan, but please know this list is not exhaustive. So some of these accommodations may include preferential seating in the classroom, extended time on tests and assignments, reduced homework or classwork, verbal, visual, or technology aids, adjusted class schedules or grading. So for example, being excused from the physical education class, verbal testing, excused lateness, absence, or missed classwork, pre-approved nurse's office visits and accompaniment to those visits, and access to elevators. It is important to note that Section 504 plans can vary in duration depending on the condition for which the child qualifies. So for example, a child with significant injuries could qualify depending on how their injuries impact their functioning for an extended period of time versus someone with a chronic condition like asthma that doesn't necessarily resolve overnight. So here are some conditions that could potentially qualify a child for a 504 plan. Again, this list is not exhaustive, but just to kind of familiarize you all with what could qualify. Asthma, ADHD, a cancer diagnosis, concussions, diabetes, epilepsy, IBD and IBS, a mood disorder, sickle cell anemia, and Tourette syndrome, just to name a few. So here I've provided for you an example of what an accommodation list could look like for a child with asthma with a Section 504 plan. So a couple to highlight here. This child could potentially require an emergency action plan that is created by the school nurse. They could require modifications to their activity level at school. They may ask that the school remove allergens from the environment, since the allergens could trigger and worsen their asthma. We could modify field trip experiences to better meet their health needs, and modify attendance policies if the child needs to be attending more doctor's appointments or needs to have more absences based on how they're feeling. And then here we have an example of a Section 504 plan with accommodations list for someone with a concussion. So some of these may include preferential seating. So that's essentially sitting closer to the teacher in the classroom. Extended time on tests and assignments to help with maybe that concentration, focus, or headaches that might come along with a concussion. Providing copies of notes. So maybe a classmate or peer provides the child with notes, or the teacher does. Wearing sunglasses in the classroom if that's needed to reduce their headaches. So let's shift to talk about individualized education plans, or IEPs. IEPs provide individualized education services and related services to meet the child's educational needs. Due to the child's disability, the curriculum and/or expectations regarding student achievement are modified. There are two general eligibility requirements for a child to qualify for an IEP. So first, a child must meet one or more of the 13 specific disabilities listed in IDEA. And two, the disability must impact the child's educational performance and/or ability to learn in the general education environment. The key difference between IEPs and 504 plans is that children who cannot access the general education curriculum without specialized services and supports likely require an IEP. Those who only need accommodations to access the curriculum likely only require a 504 plan. The IEP includes annual learning goals that are addressed through specialized service providers, like special education teachers, physical therapists, occupational therapists, speech language therapists, and school psychologists. These services are built directly into the child's IEP based on evaluation results. The plan will also include appropriate accommodations and/or modifications to the child's educational experience, and I'll show you some examples of these in a moment. Something I want to note is when a parent requests an evaluation in writing to assess if their child is eligible for an IEP, the school by law has 120 days to complete this evaluation and review results with the family. Many public schools do not meet this deadline. The child's IEP must also be reviewed and updated annually, and the child must be reevaluated for eligibility every 3 years by the public school. Parents are not required to pay for these evaluations under IDEA. So these are the 13 broad categories under which a child could qualify for an IEP. They call it eligibility determination in the special education world. So this includes autism, deaf blindness, emotional disturbance, which is a catch-all for any mental health related concern, hearing impairment, intellectual disability, multiple disabilities, orthopedic impairment, other health impairment, which notably includes ADHD, specific learning disability, speech or language impairment, traumatic brain injury, visual impairment, and developmental delay. So now I want to move into some sample components of an IEP just to help you get a sense of what this looks like for children and their families. So this sample IEP is for a child who would be under the eligibility determination of emotional disturbance. So here you'll see an annual goal for math and reading. You'll note that the goals include the specific skill to be addressed, the level of mastery expected for the child, and the date by which the skill should be demonstrated. Parents also should be receiving quarterly progress reports from the school to help them assess how their child is progressing on their IEP goals. So Parents should not have like no awareness of how their child is doing. They should be getting these updates from the school, and they are forms that are sent home to let them know how their child is doing. Here's a sample outline of services provided based on a child's educational needs. Note that this IEP outlines services from multiple providers given their educational needs. So you'll see here services in math, reading, and writing, as well as social, emotional, and behavioral needs, as well as study skills. They put here the service provider who is required to provide those services, how often those services are to occur, and in what setting. What you'll see here in this IEP is this child is only spending 10% of their time in the general education setting. So that helps you get a sense that 90% of their time is actually within a special education classroom or setting. So that's something also that is talked about during regular meetings, is how much time a child is spending in their general education versus special education. And then here, another component of the IEP is the list of accommodations and modifications. I'll just name a few here. Again, these are flexible based on the child's needs and their disability. But this child here has an alternative schedule as needed to support their behavioral concerns. They receive breaks when they are available based on their frustration level. They're allowed to complete tests and assignments in an alternative location. The length and content of assignments can be modified as needed, and calculators are provided for math tests. So here I've kind of summarized the differences between IEPs and 504 plans. So I'll just highlight the key differences here. So an IEP is a plan for how a child with a qualifying disability will access the education through both special education and related services to make sure they're making meaningful educational progress. Where the 504 plan is for a child with a disability or impairment who needs to access the education through regular or special education services and related aids and services to make sure that they have the same access to learning as their general education peers. IDEA governs IEPs, where Section 504 governs 504 plans. To be eligible for an IEP, the child has to have one or more of 13 specific disabilities, and the disability has to impact their educational performance and/or their ability to learn from the general education curriculum. Whereas for a 504 plan, a child has to have a disability or impairment that impairs a major life activity, but it does not have to directly impact the child's learning. The evaluation process for IEPs, parents have to consent to an evaluation. They have to gather multiple forms of information during that evaluation, and they have 120 days to complete the evaluation and determine eligibility. Whereas for 504 plans, the parents must also consent to an evaluation, but the school can provide accommodations without an evaluation process. They also utilize multiple forms of information for their evaluation. Supports provided through an IEP are accommodations and modifications, whereas in Section 504 plans, you can only provide accommodations. So to explain this a little bit further, accommodations reduce or eliminate the effects of a disability by changing how a student demonstrates their knowledge. So this could be in the presentation, the response, timing and scheduling, and the setting. Modifications are what we call kind of a more intensive level of support for children. So it changes what they're intended to master, typically requiring learning less material or learning material below grade level to really fill in those foundational gaps that are present as a result of the disability. Students can be tested over easier or less complex problems as a result of modifications. So some important notes about the meeting schedule for IEPs and 504 plans. These meetings to start with IEPs, these meetings are called admission, review, and dismissal, or ARD meetings. These meetings must occur annually. So every year, parents should be meeting with the multidisciplinary team at the school to discuss their child's progress and update goals. And then a reevaluation must occur every 3 years, again, per the school completing that evaluation. Parents can request a formal meeting at any time of the year to discuss with the team how their child is doing. Although certain amendments can be made without a formal meeting. So if there's a typo in the IEP or they want to make a small change, parents can sign off on those without a meeting. Although if they don't want to, they could always request a meeting. At these meetings, a multidisciplinary team attends. So these are like all the different service providers, general education teachers, special education teachers, administrators, all the different folks who are involved in a child's education, including the parents and anyone else that they want to bring with them. There are other types of meetings that can also occur, but it's just for parents. It's important for parents to know they can just request these at any time. 504 plans are not under as strict regulations when it comes to annual review and reevaluations, but best practice is to review and update those plans regularly as well. Okay, so now for what the role is of the PCP in this process. So in thinking about your role, I think it's important to first highlight barriers to evaluations and services that our families and children experience. So many of the families that we serve experience a wealth of barriers, and it's really important to consider these when you're having visits with these families. So first, there's often a lack of knowledge about IEPs and 504 plans, including that these services even exist, and that there are even designated timelines that schools have to follow. Families do not also understand how these services could make a significant positive impact on their child's educational attainment and experience. Also, their rights under that legislation that I discussed earlier. Many families that I have worked with, even here at the FHC, do not know their rights as a parent under this legislation. So I've worked with families here who have said that they requested an evaluation for an IEP at the beginning of this school year, and the school still has not completed the evaluation, and now we're in May. So they have clearly missed that 120-day deadline. By law, this family could seek out legal services to file a complaint against the school for not meeting that deadline. But again, we have to think about the additional barriers that our families would experience to even go and get legal services. Language barriers. So for our families who do not speak English as their first language, just regular communication with the school can be difficult. Interpreters are not always available at schools on demand, which impacts their ability to talk about their child's performance and make these requests without overcoming barriers. Stigma is also a really important barrier to consider as well. I've worked with families in the past who really worry about the impact of a diagnosis or a label on their child's educational experience. And some really fear that their child will be treated differently. So therefore, they would just rather them not have services at all. And they never tell the school that the disability is present. Understaffing in schools is a major concern as well. Many do not have the staff needed to meet the demand of their special education population. In some districts, one school psychologist travels between multiple sites across the week. And I will note that this impacts how some schools recommend service schedules. So if they know that they can only provide, based on the school psychologist schedule, 30 minutes of counseling a week, that might be all that they recommend for the child, even if they might need more. I will note that that's not how service recommendations should be made, but schools sometimes are doing that. Financial barriers. So parents may be unable to afford outside evaluations. These can cost thousands of dollars to get completed if you pay out of pocket. But I will note in some states that can be a faster process to getting the evaluation done and getting that formal diagnosis. So that's another barrier our families may experience. And then thinking about the parents' own learning differences and chronic health conditions. So this can impact their understanding of the services available, their communication with the school, and their ability to even get to the school in person to talk with teachers and administrators. So since you're already screening, diagnosing, and treating many of these concerns in well child visits, it's important to know what to suggest to families after providing these diagnoses. So here's some examples of what you can educate families about. You can talk to them about the relationship between health conditions, learning differences, and educational attainment. You can give them some information about the basics of IEPs and 504 plans. You can talk about the importance of accommodations, modifications, and/or specialized services to address a child's specific needs. You can help them understand the differences between accommodations and modifications. You can also talk to them about how to ask the school for an evaluation and really emphasize that the request should be made in writing and specifies what they want their child evaluated for. You can support them in learning how to ask for an ARD meeting and communicate concerns about the child's performance. I will note that these multidisciplinary team meetings can be really intimidating for families if you think about them being perhaps the one person, the one parent at the table, and then you're faced with 5, 10, 15 different folks from the school who are working with the child. It can be really hard in that situation to disagree or express concern. So really supporting the parent and understanding how to do that, even when they're in that challenging dynamic. You can help them understand questions to ask the school about their child's progress or about their services. You can help them understand about interpretation services and translated documents in this process. So schools should always provide an official interpreter. Children should never be the interpreters for their parents. I've seen this happen. It is putting the child in an awful position, and having the child communicate between a teacher who is expressing concern to the parent. It just doesn't work. So they need to have interpreters available. And all documents should be translated into their parents' native language. Schools have the ability to do that. They have the funding. They can outsource to have that translated. So parents should be able to read through this document because it is a formal legal document before they're signing. And then, of course, let's talk about college and higher education, because this doesn't end just as high school is completed. I think helping our patients understand that they can communicate with disability services on campus. I will tell you, folks that I've met with here at the FHC, many don't even know that these services exist and that they can ask for accommodations, as well as helping them to communicate with their professors, since a lot more of the onus is on our patients as they get to these higher levels of education to really advocate for what they need in the classroom. Okay. Yes. And then next, I want to talk a little bit about how you can support your patients through collaboration and advocacy. So first, I'm working with the family. Discuss how you can support the family with getting their needs met outside of the clinic. Advocate for the need for services to help families understand the importance of communicating with their child's school. And get copies of evaluations and IEPs and 504 plans to have on record, especially as our patients are getting older and can technically sign for their own services here at the clinic. We need to actually understand if their disability is impacting their medical decision-making ability. So having those documents on record can really help us understand if we need them to be like appointing someone to make their medical decisions for them. In working with the school, something that you can do is provide the necessary documentation to support the evaluation process. So sometimes schools want a letter outlining the diagnosis or any potentials, accommodations, or recommendations that you have. You can advocate for the child to receive services or a change to services based on what you're learning and witnessing during well child visits. You could always schedule a meeting with a school administrator, school psychologist, or teacher, whoever may be the best contact person. I will say every school is a little bit different, and I find meeting with administrators is a little bit more effective because they understand some of the legislation, as well as have more power at times than teachers to make changes. Working with specialty providers. So ask any questions about treatment recommendations that may impact the child's access to the education. Get releases of information so you have a clear picture of the child's treatment with other providers, especially if this isn't automatically included in EPIC. We really need to get a sense of the child's progress because we really don't want to be waiting from one year to the next in a well child visit without addressing these issues, because that's a lot of learning lost for the child. Of course, also working with your BHCs, we can provide curbside consults, warm handoffs. We can get releases of information signed for the school. We've also scheduled school meetings this year to speak to schools and advocate for our patients' needs. And then also consider other ways to support the patient, or the parent of the patient. So does the parent, for example, have their own mental health or chronic health condition needs that need to be addressed? If so, are they a patient here at the FHC? Can we get them connected to the behavioral health service? Or do they need some new parent management strategies to help them with supporting their child at home? Also, for policy, pay attention to state policy and learn ways to advocate for change in legislation and address concerns with how services are rendered in your state. Now, what happens if you work somewhere without a BHC? Well, I would say that's not preferred. That is okay. It still exists. And there are still ways that you can support these families. So in addition to any of the bullet points that I named on the last two slides, you can always schedule a follow-up visit to just discuss this concern. Providing the parent with some basic resources and/or questions to ask can be really helpful to get that process rolling. Collaborating with the school may also really be key depending on how well the child's needs are being met. You could schedule a 15-minute meeting with the school and perhaps also the parent if that would be helpful, just to help clarify questions, address concerns, and get the child access to the services that they need, particularly if the school is not abiding by the regulations outlined by IDEA in Section 504. So here I've highlighted an example of how this may look in the primary care setting, and I've specifically included some new additions that you may make to your practice based on this talk today. So we'll start here at the top. Let's say you're having a well child visit. Parent expresses concerns about ADHD. Here at the FHC, we provide those families with Vanderbilt screeners, and you schedule a 1-month follow-up. Parent brings back the screeners. They meet clinically significant levels of symptoms. You diagnose the child with ADHD. Then next, you often move into medication and behavioral intervention options. Perhaps that same day there's a BHC visit. You start them on a low dose of a medication. Now here, you could also add in some education for parents about 504 plans. Tell them what it is, how it could help their child. And then also encourage the parent to communicate this diagnosis with the school. Often parents leave here and they don't think to then bring that information to the school. So reminding them of that in the visit could be very helpful. Then you schedule your 1-month follow-up. You assess the child's progress with medications and behavioral interventions. And then something else you can do now is assess progress with the school. Let's say the parent says there's no progress. They brought the documentation to the school, they told them what was going on, and nothing happened. Maybe during that visit, you get a release of information signed to contact the school to help advocate for those services. So with everything that we just discussed, I want to come back to our vignettes. I'm going to read through these again for you and ask you to come up with 1 or 2 additional ways that you can support these patients based on our talk today. So Dominic is an 8-year-old Latino male presenting to his first well child visit at your clinic. You learn from Dominic's mother that he has a previous medical history of Crohn's disease. Dominic and his family recently moved to San Antonio, and Dominic is reportedly having a difficult transition to his new school. His mother shares that he has had 3 accidents where he does not make it to the restroom in time to have a bowel movement. His teachers report that there have been some instances where he was not able to immediately use the restroom because they were in the middle of a lesson or transitioning to a class such as gym or art. Dominic is embarrassed and has already missed 10 days in the first 1 to 2 months of school due to his GI symptoms. So go ahead, jot down 1 to 2 additional ways you could support Dominic and his family. And maybe we can have some of you share in the chat what you might do differently based on the talk today. Okay, excellent. So I hear about better control of the Crohn's symptoms. Offer a 504 plan discussion. Wonderful. Perhaps the family doesn't even know that they could have a 504 plan for Crohn's disease. Absolutely. So helping the mother understand how to talk to the school about this concern and possible accommodations that their child may need. Perhaps this kiddo, for example, some schools have rules about when kids can leave the classroom. Maybe this kid needs a little card that they lift up and they can just leave the room and go to the restroom when needed versus having to wait, ask permission, or have the teacher tell them that it's okay to go. Yes, allowing for breaks for the restroom. Emphasize that the school is required to do it. Absolutely. Dominic is now missing a significant amount of school, which is going to very negatively impact his educational attainment. So we need to, first of all, get him back in school and also feel like he can use the restroom as needed so that he's not having accidents, because that is really difficult for an 8-year-old to experience. Great examples. Okay, so let's move into our vignette about Josie. So Josie is a 10-year-old Chinese American female presenting to her well child visit. You followed her for several years across her well child visits, and parents continued to report progressively worsening school performance, C's, D's, and F's. Teachers have reportedly described Josie as a slow learner in reading, and parents have been told to hire a tutor. However, Josie's family is unable to afford these tutoring services and are concerned about her declining performance. Her parents report that she has never been evaluated for a learning disability, but both of her parents noticed a difference in her reading abilities compared to her older sister. So based on our talk today, what are 1 to 2 new things that you learned that you can do to support Josie and her family with these concerns? And go ahead and type those in the chat as well. Yes, absolutely. The school has to pay for the evaluation and the services. They have to do it. Yes, encourage the parents to request an evaluation, and especially putting that in written form, right? So unfortunately, schools can say, oh, we didn't know that conversation happened. We have no record of it. When parents write it, it's there in writing. They can't dispute that the request occurred. Excellent. Something that I made sure to include here, because I think schools sometimes do this, is they put the onus back on the family to get this tutor. It's not up to the family, especially if this child has a learning disability, to find these services. So getting that evaluation through the school is key. Anything else that you might do to help support this family? I think something to, yeah, give them a tip sheet, absolutely, to use for requesting those ARD meetings and how to communicate their concerns and what to ask for. Maybe even helping the family understand what a learning disability is. Sometimes our families don't quite understand that and don't understand that these services can exist to support their child and how it will support their child. Beth also said explore and address stressors related to learning or anxiety that can be addressed behaviorally. Absolutely. So sometimes we find with our kiddos with learning disabilities, they're compensating in some ways in the classroom, and perhaps there are some behavioral or emotional concerns that are co-occurring. The school has to pay for these services. They do, and saying, I know by law that you have to complete this evaluation and you have to provide these services. Schools can kind of jump to it once they hear a parent say that. But again, when parents don't know, unfortunately, those needs are not met. And that can also help alleviate too any parental stress around how am I going to afford this? How am I going to get my child this evaluation? They don't have to. The school has to pay for it. They have the funds for it. Great. Okay. So let's move into some resources. I have QR codes on here for each of these resources. So feel free to take a shot of this QR code so that you can share it with families and review yourself. So this first one is a great table for families and providers comparing IEP and 504 plans. So just to kind of reiterate some of our conversation today. So I'll leave that up for a couple more seconds. This next one is from the Texas Education Agency and their Parent and Family Resources section of their website. This has some great information about general ARD meetings, parental consent for services, and parent information and training projects. So a lot of great links here for parents. So go ahead and take a shot of that one if you'd like to open up that. And then this one here, also from the Texas Education Agency. This is a variety of resources for different topics of interest for families, specifically with children in special education. They have some awesome behavior resources, things that parents can do at home. Because these kiddos often do require that extra support at home, it's helpful for our parents to understand how they can support their kid. Again, through communication with the school, but also through some of these great resources. So leave that up for a couple more seconds. And then here's just a FAQ about Section 504 plans in schools, another great resource for both you and your families. I'll leave that up for a couple seconds. And then this is an example of a behavioral health resource that we can give here at the Family Health Center. And this is just a quick tip sheet about how to advocate for your child in an ARD meeting, just to help parents feel like they have a better sense of how they can express what they want for their child and maybe not feel really intimidated or not know what to ask during those meetings. So we can always provide this to families. Okay, so what questions do folks have?
There are a few questions in the chat box that I'll read out loud to you since we have a little bit of time. The first question is, any tips on how to get buy-in from parents that may not necessarily believe in accommodations or not wanting to put in the work to get services for their child?
That's a great question. So I would want to understand why the parent doesn't believe in the services. What is the barrier that's coming up for them? Are they afraid of the school judging their child? Are they afraid that maybe those resources just won't be provided? Do they have a misunderstanding of what special education is? I will note special education has changed drastically across the years. So back when we were children, maybe our parents' generation were in school, special education was like, put all those kids in the classroom and don't let them interact with their peers. And that's really shifted. So maybe understanding if that's kind of their lens of like, well, I don't want my kid to be in that small room all day. Well, this doesn't mean that that's going to be the case. So I think exploring using your MI skills that you've been learning through your didactics. And if they don't want to put in the work, again, I would want to know why. What is it that's getting in the way? What do they think is going to happen if they put in the work? And then also being really real with them about what this could mean for their child. Like, do they have goals for their child to graduate? Do they want them to go to college? How would they feel if their child has to be held back for a year, right? Because if the schools aren't providing those services, if we don't have a formal plan in place, children can then be held back for 1 year after the next for failing without actually getting the services they need. So providing that education could be really helpful.
The second question is essentially asking if IEPs and 504 plans are still in effect for students in charter schools.
So from my understanding, as someone who worked in a charter school, those are still public education schools. So as a result, they should also have the funding to provide these services. Where it gets hairy is private schools. So private schools do not have to provide services if they do not want to. They do not receive funding under IDEA. So that's where things can get tricky. And sometimes I've had conversations with families about maybe perhaps moving schools so that their child can get their needs met if that's private school is unable to meet those needs. Some private schools have gotten better and will bring in service providers, maybe not as comprehensive, but they have a little bit more power in deciding what they will and will not do for a child, as opposed to public schools. And again, charter schools tend to fall under that.
Great. I don't see any other questions in the chat box. We did post the evaluation link through Qualtrics. So please fill that out so we can get feedback about today's talk. Dr. Nadeau, I see you unmuted. Were you going to throw in something before we finish?
Yeah, I just wanted to make the point that I've tried to make the point several times about who pays because a lot of people find that hard to believe. But even if you can get the school to pay, it still may, cause the family something just in terms of, time missed from work and other things that they do end up having to pay for. So this still can be very strenuous for families.
Absolutely, because these meetings, let's say, meetings occur during the school day, so they have to miss work to come to the meetings. If they have a child with behavioral issues and they have to pick them up from school because of those behavioral concerns, that can really impact them. So there are definitely indirect ways in which there can be challenges, but also, again, if that child is protected under an IEP, the school needs to be doing more. If they're leaning on the parents too much to come pick them up, or the child's getting suspended, that means the school's not doing enough. So again, the need for the parent to say, okay, we need to meet as a team and talk about what we can do differently, because clearly my child's needs are not getting met. I've included here as well, just to kind of wrap up the talk for today, just a reflection to help summarize 3 things that you learned. This is just for you to write down for yourself. 3 things that you've learned, 2 ways your clinical practice in primary care will change as a result of this presentation, and 1 question you still have, or 1 thing that you want to learn more about. And then, of course, you can always come find me and any of your other BHCs in clinic. We'd be more than happy to discuss this with you more if questions come up later. Or email me as well.
Is there one other slide or?
That's it.
Okay, perfect.
The references, if everyone wants to see my.
Perfect. Thank you. Thank you all for your time today. Again, don't forget to fill out the evaluation and have a great rest of your day.
Thank you, everyone.